Okay, we'll talk about a head injury. These are the learning objectives of this uh, lecture. We will talk about generally about the head injury, how to transfer the patient of head injury, and initial assessment and grading, and then the management, emergency management, imaging, and then definitive management and prognosis of head injuries. So let's begin. Little about the introduction of head injury. These are the statistics that we are having around 50 people in 10,000 people. We are losing them. There are almost more than 2 lakh patients every year who are being hospitalized and 60,000 deaths. And almost it's 30% of the death toll of amongst the trauma. And these are about 5.3 million people are having permanent disabilities. So this is a big source of disability, uh, permanent permanent burden to the society as well. The patient becomes having permanent disabilities and they are become useless persons to the society. So head injury is a very something we can say very bad thing, in the sense that not only there's a loss of life, but if you survive, you can have some permanent sort of disability and difficult to work as a productive individual in the society. So brain injury can result from primary brain injury, that is the direct trauma, blow to the brain, whatsoever it is, whether it's the contusions, the laceration, bony injury, a diffuse axonal injury, or brainstem contusion. And then are the secondary injuries, those related to the raised intracranial hypertension due to raised ICP, are secondary to the hematomas, edema, hypoxic injuries, ischemic injuries due to the vasospasm, whatsoever secondary causes are there, we can have secondary brain injury. This is the area where the neurosurgeon can play. The neurosurgeon's role comes to prevent the secondary injury, because when the patient has come to you in the hospital, the primary injury is there. To avoid primary injury, we need to have a better traffic rules and implementation, safe traveling guidelines, and other measures, safeties in our vehicles, and all these related to the road safety measures we can adapt. But primary injury is there whenever you receive a patient. The aim of all the management is to prevent the secondary injury and treat the primary injury. Mostly we are having motor vehicle accidents from the falls, and child abuse is there. We can have a coup injury, that is direct blow to the brain structure, and counter coup injury, that is due to indirect blow to the brain structures. Know how we initially assess the patient with a head injury. This is very important. Every injury whatsoever, including head injury or the brain injury or spine injury, has to be managed in the line of ATLS guidelines. The primary management is same. You receive a patient, you see a patient, you go for primary survey, you go for ABCD first, then you go for secondary survey. And for a patient with a head injury, you go for detailed survey related to secondary survey related to the head injury. After initial assessment, of ABCD, then you assess for GCS, that is the conscious level of the patient. That's very important. And you classify the patient according to the GCS into the mild, moderate, and severe head injury according to the GCS score mentioned in this slides. Then you stabilize the patient. After stabilization, you go for detailed examination of the patient. Detailed examination of the patient includes different parameters. First of all is the visual inspection of the cranium. You go to see any evidence of base of skull fractures. You check for panda eyes, raccoon eyes for the battle sign behind the pinna. You check for any CSF rhinorrhea, any laceration to or bleeding through the external auditory canal. You assess the patient for facial fractures, leaf-fold fractures, orbital fractures, or periorbital edema and ptosis. You assess craniocervical, you go for craniocervical auscultation. You can auscultate for carotid injuries in the neck to rule out carotid dissections that will affect lead to the ischemic injuries to the brain. You should assess for keratoconus fistulas. If the proptosis or eyeball swelling is there, there can be the CCF, keratoconus fistula, that can later on lead to blindness or visual impairment. You go for physical examination of the spine as well. Brain injury is related to this, especially to the cervical spine. It's said that in a patient with a head injury, there is supposed to be having cervical spine injury until proved otherwise. So you assess for the cervical spine injury and stabilize the cervical spine with the Philadelphia collar in any patient of head injury as well. You go check for the any evidence of seizures, maybe the single, multiple, or they can be the status epilepticus. These are the picture of battle signs. These are the raccoon eyes, the periorbital ecchymosis is there, and you go for these in the presence of periorbital ecchymosis, raccoon eyes. Raccoon is a animal, and the eyes of this raccoon matches to the patient of head injury. The raccoon eyes shows there's a can be the basal base of skull fractures, and very important to check, go for optic nerve injury. When there's eyeball swelling, there is patient is unconscious and he's unable to tell you that whether he's having blindness or visual impairment or not. It's very important. You go open these eyes and go for direct and indirect light reflexes. If they are normal, then the optic nerve injury is not there. If there's any problem, abnormality in light reflex, pupillary light reflex, there can be the dilatation, there can be RAPD. So you have to go for assessment of optic nerve function. It's very important that when the patient after 2-3 days, when he become awake, he will say, oh, I can't see from this eye or that eye. Then the time to manage or treat that optic nerve injury actually has passed. It's very important that you have to go for optic nerve decompression within 24 hours. So in the presence of raccoon eyes, go for assessment for optic nerve injury. You go for the neurological assessment for cranial nerves, as I've said, optic nerve, light reflex, facial nerve. You go for sixth nerve assessment, extraocular eyeball movements. You go for the motor system examination, sensory system examination, and reflexes as well. How to transfer a patient with rescue a patient with head injury? These are general guidelines you avoid for hypoxia and hypotension. That's very important. So whatsoever the route of transportation is there, you have to be careful that there is no hypoxic or hypoxia to the patient, or there is no hypotension, because these are two main killers in neurosurgery. You give the patient oxygen, you make sure that the blood pressure is continuously being checked. And then are other things you have to be careful about the anemia. If there is a massive blood loss from the scalp or any vascular major vessel injury in the neck, carotid injury can be there, or any other major base of skull vessel injury can be there. So you have to replace the losses. You have to be careful about seizures. Uh, you have to warm the patient to check the temperature, because patient can develop hypo or hypothermia, and you have to stabilize the neck. So these are uh, basic things we have to careful when you are transferring a patient with a head injury. No, the emergency treatment is again the same: blood pressure and oxygenation. Blood pressure management, you give the patient IV fluids, you give the patient oxygen either through face mask, nasal cannula, or intubate the patient. If there is having GCS below 8, that's the indication for intubation of a patient. Any head injury patient who is having GCS below 8 should be intubated as a rule of thumb. Then, to maintain the airway or ventilation, you hyperventilate the patient. This is not elective hyperventilation. You hyperventilate the patient if he's unconscious and having a GCS below 8 as a preliminary measure to control or reduce intracranial pressure, ICP. You can give the patient diuretics, mannitol, furosemide, hypertonic, depending upon the blood pressure of the patient. You can give a shot of mannitol or other diuretics. Mannitols, this is a dose of mannitol. You can give over 20 minutes in a bolus. You should give patient anti-epileptics. Then you go for CT imaging. That is the brain. CT brain plane is the gold standard investigation. In a patient, every patient had injury, the CT is not done, his workup is not complete. This is the only investigations, and this is the best investigation we can have. In any patient having these things, you should go for CT, even if the GCS is normal. A patient having vomiting, age is greater than 60, he seems to be intoxicated, his short-term memory loss is there, physical signs of severe trauma is there, like clavicle fracture. If there is a post-traumatic seizures, GCS less than 15, is there is a focal neurological deficit, or a patient having abnormal coagulation, there is a risk of any hematoma formation, you should rule out with the CT. No, the management, basic management, that was the initial trauma management. Now, detailed management. You classify the patient according to the head injury guidelines. If the patient is having 14 or 15 GCS, that's a mild head injury. You have the options to either admit the patient, or you can send him to the home. You can observe him for 24 hours to rule out any delayed or secondary injury, but you can send the patient to home with the head injury guidelines. What are those head injury guidelines? You advise the patient to attendant to observe for any abnormal behavior, in severe headaches, any neurological deficit, loss of consciousness, intractable vomiting, or anything abnormal in the patient's behavior. You advise the attendant patient immediately to rush to the hospital and repeat a CT scan of the patient if any of these things is there. But if patient remains safe for 24 hours, the patient with mild head injury can get away with his head injury management. But you have to admit a patient. If you have to admit a patient, these are the general measures for every minor major head injury. You will keep the elevate the head to 30 to 45 degree to minimize the ICP. You go for neurological examination every 2 hours. You keep the patient NPO. If then he's having any drowsiness, if the patient is okay, then you can allow for some clear fluids. You give patient fluids or analgesic, antiemetics, or anti-epileptics. You can give the patient painkillers. Now, if a patient is having a GCS 9 to 13, that is amongst the moderate injury, head injury, you have to have admit that patient, and you have to monitor in ICU, neurosurgery ICU. You have to go for ICP ICP monitoring if needed. You can have to go for any surgical intervention, but generally you admit the patient on the floor in the ICU from 9 to 12, but GCS above you admit on this floor. And you can repeat the CT whenever it is needed. No, ICP monitoring is a very important subject. If a patient is having severe head injury or mild head injury, you can have to have ICP monitoring. But especially if a patient having normal brain CT and his GCS is less than 8, this patient of severe head injury with normal CT, you have to have monitor for ICP if he's either having motor posturing, his age is above 40, he's having low blood pressure. If a patient with severe head injury who is having any abnormality in the CT scan, there is any edema or swelling, there's a hematoma or contusion, or there's a compression of the basal cisterns, you have to have managed, go for ICP monitoring. It's very important. These are the different types of ICP monitor. This is intraventricular device. This is intraparenchymal device. This is subarachnoid bolt device. This is subdural bolt. So anything type of monitor you can attach to the ICP monitor and again to the drainage bag, for particularly for the intraventricular. If you are using the intraventricular monitor catheter, you can assess any raise ICP and you can reduce the ICP by draining the CSF. It's diagnostic as well as therapeutic. So when it's needed to be operated, you have three options. You can go for the exploratory burr hole. You can go for a simple burr hole and remove the clot. You can go for craniotomy and remove the clot or pathology whatsoever it is there. But if there is a massive injury, there's a massive brain edema, and whole of sometimes one side of the skull is involved, you go for decompressive craniotomy. You remove a whole side of the skull and open it up, open the dura, and give the brain space to expand. This is a patient who underwent head injury, and he was having, this is a picture of decompressive craniectomy. Almost half of the cranium was removed on one side. The brain was given space to expand, to brain edema to develop, so that there is no midline shift, and internal vital structures remain safe. After a patient has been improved, we have applied the bone again its normal place. So it's very important to know about the prognosis of head injury. Oh, the prognosis of head injury is bad. Many times patients do have some permanent neurological deficits. They can be amongst the motor skills, speech, vision, hearing, taste, whatsoever the brain area is damaged, you can end up with some sort of disability. And then with these, if there is no focal disability, patient can have personality or behavioral changes. They can be long-term or short-term, and they can be very disabling for the family, for the person as well, and patient can have people can have loss of job, loss of relations, and the family sometimes they behave in a way that they can manage their day-to-day activities, and they become useless citizens of the society and burden to the societies. Sometimes you have to give them long-term medical and rehabilitative support in sense of physical, occupational, and speech therapy. So it's the key to avoid the head injury is to promote a safe environment to avoid head injuries. Prevention is better than cure. So prognosis of head injury is bad. It's better to avoid it. You have to adapt road safety measures. You have to be careful in household for the kids and elderly adults. They because with the trivial trauma, little falls, they can end up with a massive head injury. You have to have a safe environment rather than investing on the treating a lot of patient who can become burden to the society. Thank you very much for your patience.